So, how the resolution occurs? Okay, how can I treat that? I have to treat the vomiting. If I continuous RT aspiration, it is causing acid loss, it can continuously will generate a metabolic alkalosis. Treat a GI loss. If not able to control the vomiting and all, you can prevent the acid secretion by ranitidine or proton pump inhibitors. Okay, you can give saline loading. I already told that. So, it is a hypochloremic condition. So, I want to give a hyperchloremic solution. Whichever the hyperchloric solution available in a ICU is a saline. Okay. So, saline had a higher 154. The body chloride is around 100. The saline contain around 154. Okay. If I give the chloride, high chloride solution, what will happen? It is restore the ECF volume. If I give my patient is hypovolemic, that is the reason the kidney is conserving sodium. So, it is generating a metabolic alkalosis, worsening the metabolic alkalosis. If I restore the volume, my hyperaldosteronism condition is aldosterone level will come to the normal. So, acid secretion will decrease. If acid secretion decrease, then by adding of bicarbonate will decrease. Okay. So, the secrete. So, other thing is that we already discussed there is a pendrin activity is there. Okay. What is pendrin activity? It will secrete bicarbonate, it will absorb the chloride. So, if the patient having hypochloremic condition, the bicarbonate secretion is inhibited here. So, if I adding more chloride fluid, okay, if the chloride in tubular lumen chloride will increase. So, it activates the pendrin activity. So, chloride will be absorbed by the pendrin to the cell. So, the bicarbonate will secrete. Okay. So, the GI loss, proton pump inhibitors we can give, the saline loading. Okay. This is one of the few conditions we will use normal saline in our ICU. One is the upper GI loss related metabolic alkalosis. Second is the normal saline we will use for the CNS problem patients. Okay. We want to use the hyperosmolar solutions. Okay. So, this metabolic alkalosis cause chloride sensitive metabolic alkalosis, because if I give the hyperchloremic fluid, it will correct my metabolic alkalosis. These are chloride sensitive metabolic alkalosis. The GI cause metabolic alkalosis are called chloride sensitive metabolic alkalosis. Okay. The urine chloride will be less than 20. You have to do other treatment is the potassium correction is very important. Okay. Why the potassium correction? You have to correct all, right? You have to correct hypochloremia. Okay. You have to correct potassium also. Why the potassium correction is very important? Because, okay, so whenever this is my blood, okay, my blood having low potassium, what body will do? It secretes the, whatever the one positive molecules move from intracellular to the blood, so opposite, my hydrogen ion will move from the blood to intracellular. So, if hydrogen ion moves from blood to the intracellular, what will happen? The one bicarbonate level will added in the blood. So, that is one reason the hypokalemia can cause rarely metabolic alkalosis, or it can maintenance the metabolic alkalosis. Okay. So, the correction of potassium also very important. Okay. So, the treating of metabolic alkalosis, treat the root cause. In the GI cause metabolic alkalosis, treat the root cause, prevent the vomiting. Or second, the acid proton pump blockers we can give, saline loading, treat the hypokalemia. Okay. Next is the renal cause of metabolic alkalosis. Always we divide the renal cause of metabolic alkalosis into two. One is the hyperaldosteronism condition. Second is a drug induced, okay, diuretics or thiazide and loop diuretics. First we will go with the hyperaldosteronism related. Some of the condition, primary hyperaldosteronism, adrenal tumor or severe Cushing syndrome, or exogenous mineralocorticoids, I am giving hydrocort to the patients, or renin secreting tumor. Some of the genetic condition called Liddle syndrome. Liddle syndrome, nothing, to increase the ENaC activity. So, how the renal causing the renal, some renal condition causing metabolic alkalosis. I already told in the GI cause, low volume status is causing metabolic alkalosis one, maintaining the metabolic alkalosis. But if example, if I had trauma or I lost 1 to 1.5 liter of blood, this is also hypovolemic, hemorrhagic shock, hypovolemic condition, but those patients won't develop metabolic alkalosis. Why they are not developing a metabolic alkalosis? Okay. So, normally in a secondary hyperaldosteronism, non-GI causes won't cause metabolic alkalosis. Why? Okay. Whenever my volume, extracellular fluid volume decreases, what will happen? The body, the kidney trying to absorb more water, more sodium and more chloride. Okay, this is simple. Okay. In the proximal tubule, what will do? The body will absorb more sodium because the body want to retain, because already my extracellular volume is, I am hypovolemic. More sodium is absorbed. Each molecule of sodium absorption will cause one hydrogen ion secretion, one bicarbonates are added to the blood. One. Okay. But if I absorb more sodium here, the distal delivery of the sodium will be low. One. This EC volume also increase the hyperaldosteronism. Okay. In the normal physiological status, non-GI cause condition, okay, there is no generation of metabolic alkalosis here. In a GI cause vomiting itself adding lot of bicarbonate, the kidney is maintaining the metabolic alkalosis, not causing the metabolic alkalosis. Here the ECF volume, some bleeding or whatever that has some reasons hypovolemia, okay, decreased oral intake. Usually it won't cause metabolic alkalosis. Why? Because there is no generation of metabolic alkalosis here. But the ECF volume increase the hyperaldosteronism. This hyperaldosteronism, what will happen? It is trying to absorb the more sodium here, but because of the proximal more absorption of sodium, the distal delivery of the sodium will be low. So that is the reason, despite of contraction, hypovolemic status, non-GI cause won't cause the metabolic alkalosis. See here, the contraction status, whatever there is a bleeding or a decreased oral intake, non-vomiting or it won't cause generation of metabolic, because secondary increased aldosterone will occur, but the increased proximal sodium absorption decrease the distal delivery of the sodium here, because the ENaC activity is high, but the sodium delivered to the distal is very low. It cannot absorb more sodium. So, there is a decreased distal delivery of sodium. The hydrogen ion secretion also will be low. The decreased hydrogen ion secretion, so decreased absorption of bicarbonate. So, the bicarbonate won't increase. So, that is the reason there is a no metabolic alkalosis in the normal non-GI cause hypovolemia. Okay. If you see what is happening here in a GI cause, okay. Now, then how causing a primary hyperaldosteronism causing a metabolic alkalosis, okay. In a hyperaldosteronism, what happens here? It is an increased aldosterone. Example, adrenal tumor. It is secreting a lot of aldosterons. These aldosterons, what will you do? It is going to increase the ENaC activity. So, the sodium absorption will increase. Every sodium absorption, it secretes the one hydrogen ion. Each hydrogen ion secretion will add the one bicarbonate. So, this increased activity, it increases the bicarbonate in the blood. One. What happened here? In a contraction and hypovolemic condition, the ECF volume will be low. Okay. The ECF volume will be low, the proximal sodium absorption will increase. Here, the ECF volume is higher than the normal range. Okay. So, the proximal sodium absorption will be low. Because of this, the increased sodium delivery here, increased sodium delivery associated with increased ENaC activity, it will increase secretion of more hydrogen ion, it will increase the blood bicarbonate. So, the decreased proximal sodium reabsorption, increased sodium, distal sodium delivery, so increase the hydrogen ion loss or increase the bicarbonate gain. So, it is hyperaldosteronism generate and maintaining a metabolic alkalosis. This is the how hyperaldosteronism causing the metabolic alkalosis. Okay. So, next is the how the clinical picture will present to you with the patient with hyperaldosteronism cause metabolic alkalosis. I already told. Hyperaldosteronism, any metabolic alkalosis, patient pH will be more than 7.45. Okay. Bicarbonate more than 24. Okay. Second is all metabolic alkalosis associated with hypochloremia 2. All metabolic alkalosis associated with hypokalemia. The ECF volume will be normal or high. Patient used to have hyperaldosteronism. Patient used to have more sodium absorption, more water retention. They used to have hypertension. This is for example, in the GI cause, what will metabolic alkalosis will be there, hypochloremia will be there, hypokalemia here. The ECF volume will be low in GI cause. BP will be low. Okay. What about the urine chloride? Will be more than 20. In hypovolemic condition, the kidney trying to absorb more sodium, more chloride, okay, more water. Here, there is no hypovolemic status. So, the urine chloride will be, excretion will be normal, it should be more than 20. In a GI cause of metabolic alkalosis, the urine chloride will be less than 20. In a hyperaldosteronism condition, urine chloride will be more than 20. This is the one way you can differentiate the GI cause or non-GI cause. Here, the urine chloride is more than 20. Even if I give normal saline in this condition, the metabolic alkalosis won't be corrected. So, this condition is called chloride resistant metabolic alkalosis. In the GI cause, if I give sodium chloride, normal saline, it will correct my metabolic alkalosis. Here, it won't correct my metabolic alkalosis. Those GI causes, a high chloride content solution correct my metabolic alkalosis is got chloride sensitive. This hyperaldosteronism condition, the hyperchloremic solution won't correct the metabolic alkalosis. This is called chloride resistant metabolic alkalosis. Okay. So, how can I treat? So, low salt diet. Low salt diet means the low sodium delivery to the distal tubules. So, the bicarbonate generation will decrease. I can give the aldosterone antagonist. If I example the hyperaldosteronism causing metabolic alkalosis, if I give the aldosterone antagonist, it can prevent or treat the metabolic alkalosis. Always correct a hypokalemia. Without correction of hypokalemia, your metabolic alkalosis won't be corrected. Always in this hyperaldosteronism, you have to blood pressure management also very important. Okay. Other causes of renal cause of metabolic alkalosis. One is a loop diuretics. It is block the sodium potassium chloride channel. Okay. This is a loop diuretics, we inhibit that. So, it causes metabolic alkalosis. That is a congenital syndrome, decreased activity of this channel, okay, can cause metabolic alkalosis. This is a Bartter syndrome. The thiazide channel, this is loop of Henle. Okay, then the distal convertile tubule, sodium chloride symporter, co-transporter, thiazides will inhibit that. The congenital syndrome decrease the activity of this channel, it will cause metabolic alkalosis. So, thiazide diuretics will inhibit the sodium chloride co-transporter. Down regulation of this co-transporter in the congenital syndrome is Gitelman syndrome. Okay. How these loop diuretics or thiazide diuretics, Bartter syndrome, Gitelman syndrome all causing metabolic alkalosis? It's very simple. If example, this is a loop diuretics, this is a sodium, potassium and chloride channel. Okay. This is blocked here. Okay. The sodium absorption is decreased. So, if a sodium absorption decreased here, there is an increased sodium is delivered to the collecting tubule. Increased sodium is delivered to the collecting tubule. This sodium will be absorbed here. Each molecule of sodium absorption, it will secrete acid. Each acid secretion will add one molecule of bicarbonate. So, increased sodium delivery here, increased sodium absorption, so leads to increased bicarbonate in the blood. Okay. This is the reason, one method, the loop diuretics causing metabolic alkalosis. What is the other problem here is the loop diuretics also will cause low ECF volume. This low ECF volume will activate the hyperaldosteronism. It also increases the high ENaC activity, which is, this is the way it's contributing a metabolic alkalosis. The Bartter syndrome is, these channels are down regulated in the congenital disease, it's a Bartter syndrome. Okay. In a thiazide diuretics, okay, what happened to the thiazide diuretics? I already told it's a sodium chloride co-transporter. Okay. This sodium chloride co-transporter, it is inhibited by the thiazide diuretics here. Because it is blocked, increased sodium delivery here. The same thing, increased sodium delivery to the distal tubule, the sodiums are absorbed, each molecule of sodium absorption will secrete one hydrogen ion, each hydrogen ion secretion in the lumen add one bicarbonate to the blood. So, this is the way my loop diuretics and thiazide diuretics cause metabolic alkalosis. The same channel, the sodium potassium chloride channel blocker is Bartter syndrome. This is the sodium chloride co-transporter, down regulation is congenital syndrome is Gitelman syndrome. Okay. So, how will it's maintaining the metabolic alkalosis? The thiazide diuretics and loop diuretics generating a metabolic alkalosis. This is the way, because increased sodium delivery to the distal tubule. This same condition, this volume loss, what will happen? It causes secondary hyperaldosteronism. So, it increases the hydrogen ion loss and bicarbonate gain. So, it can cause persistent metabolic alkalosis. Okay. How will be the picture? Already told, these are all common for all metabolic alkalosis. Metabolic alkalosis, hypochloremia, hypokalemia. Here there is a volume loss will be there. So, it will be a BP will be low or normal. The ECF volume will be low or low normal range. The urine chloride will be variable in a diuretics. Okay. Whenever I am giving a diuretics, I am checking a urine chloride, it will be high. In between that diuretic, example, I am giving a morning and night dose of diuretics. If example, I am giving diuretics, I am checking urine chloride, the urine chloride will be low. In between, I am giving a morning and night dose, I am checking a urine chloride in the afternoon. It is a off diuretic condition. What will happen? This diuretics will cause hypovolemia. This hypovolemia will activate hyperaldosteronism. So, more sodium and water retention. So, the sodium and chloride will be absorbed during in between the diuretic dose. So, it will cause urine chloride will be low in a off diuretics. During diuretics administration, the urine chloride will be high. So, the urine chloride will be variable in a diuretics. These Bartter and Gittleman syndrome also will cause metabolic alkalosis, hypochloremia and hypokalemia. These Bartter and Gittleman syndromes are not very important in the critical care. I am not going to discuss about how will be that urine chloride, how will be the volume status in this condition. Okay. So, how will you correct that? It's a how will you treat the metabolic alkalosis, especially with the diuretics, is you have to correct your hypokalemia. It's very important. These indirectly they are increasing the distal sodium absorption. So, I have to indirectly they are causing hyperaldosteronism, secondary hyperaldosteronism. So, you can give spironolactone or aldosterone antagonist. So, you can use you can use the other alternative diuretics like acetazolamide as a treatment also, but it will correct the metabolic alkalosis, but the acetazolamide itself will cause hypokalemia. So, these the diuretics induced, thiazide and loop diuretics induced metabolic alkalosis always associated with the hypokalemia. You can treat the metabolic alkalosis with acetazolamide, but you should be very careful about these acetazolamide itself worsen your hypokalemia. So, you have to be supplement the potassium is very important when you are using the acetazolamide to treat a metabolic alkalosis. What are the other causes of metabolic alkalosis? We already told that the hypokalemia will cause metabolic alkalosis, hypochloremia, milk alkali syndrome, exogenous loading of bicarbonate, post hypercapnic and massive blood transfusion. First, see how the hypokalemia causing metabolic alkalosis. Simple. I already told that whenever the potassium is low, this ICF intracellular to extracellular, whenever the potassium is low in the blood, this movement will cause hydrogen ions move from the extracellular to intracellular. So, the bicarbonate level will be acid moving from the extracellular blood to intracellular. So, bicarbonate level will increase. So, this is the one way the hypokalemia causing metabolic or worsening the metabolic alkalosis. Second, the second is that there is this sodium, potassium and chloride channel. This in the loop, thick ascending loop of Henle. This is the channel, it is inhibited by the loop diuretics. So, with the hypokalemia, these channels will be less active. If it is less active, the increased sodium delivery to the distal tubules, so it can cause metabolic alkalosis. This is second mechanism. The third mechanism is in a distal convertile tubule. Okay. In what will happen that distal convertile tubule, every molecule of sodium absorption, the tubules will secrete one potassium or one hydrogen ions. If I have the low potassium in the blood, so there is a less potassium is available to secrete in the lumen. So, each sodium absorption only hydrogen ions will be secreted in the collecting duct. So, each hydrogen ion secretion it will add one bicarbonate in the blood. So, it increases your metabolic alkalosis. One is the transcellular shift, second is the sodium potassium chloride channel down regulation in the loop of Henle. 3 is the collecting duct in a hypokalemia will secrete more hydrogen ions. So, these are the mechanism the hypokalemia causing metabolic alkalosis, or it can cause the maintenance of metabolic alkalosis. This correction of hypokalemia is very important. Okay. Other is a hypochloremia. Okay, all metabolic alkalosis associated with hypochloremia. Okay, in a GI cause of metabolic alkalosis, the correction of hypochloremia is very, very important. Okay, why is very important? So, the two reasons. There is a sodium chloride co-transporter. This is inhibited by our thiazide diuretics. So, to absorb the chloride, if chloride level is low in the urine, what will happen? The chloride won't be absorbed by these cells. So, what happen? The sodium absorption also will decrease. If sodium absorption decreases, there is an increased sodium delivery to the distal tubules. So, it can increase sodium absorption, increase hydrogen ion. So, it increase the blood bicarbonate. That is the one reason hypochloremia can worsen the metabolic alkalosis. The second thing, the correction of metabolism. The second thing is there is something called pendrin in a type B intercalated cell. Okay. Discussed during the renal physiology class. Here that each absorption of the chloride will secrete one bicarbonate in the lumen. If the tubular chloride is very low, the bicarbonate secretions also will be low. So, it can cause resistant metabolic alkalosis. So, how the hypochloremia worsening a metabolic alkalosis. Other condition we already discussed is the milk alkali syndrome, means it's a calcium carbonate excessive large ingestion. The bicarbonate will increase the bicarbonate level. The calcium, what will it do? The hypercalcemia will do two things. Hypercalcemia will cause diuresis, so it causes hypovolemia. This hypovolemia can activate the hyperaldosteronism. It can maintain the metabolic. This excessive ingestion increase my bicarbonate level. Hypercalcemia increase the aldosterone level. This hyperaldosteronism will maintain a metabolic alkalosis. This is a one way, the milk alkali syndrome causing metabolic alkalosis. Already the exogenous soda IV injection, I am giving a soda bicarbonate to the patient. Normally, it won't cause persistent metabolic alkalosis. Otherwise, is the patient having renal dysfunction. The excessive bicarbonate which I administer to the patients are not able to excrete through the kidney, it can cause metabolic alkalosis. Post-hypercapnic, we already discussed, if chronic type 2 respiratory failure, I washed out rapidly through the mechanical ventilation. This compensatory bicarbonate will be persistently high, it can cause severe metabolic alkalosis. Massive blood transfusion, these blood products contain citrate. One molecule of citrate can produce 3 bicarbonate molecules in the body. So, it's large volume massive transfusion, especially the large FFP transfusion can cause metabolic alkalosis by these mechanisms. Okay. So, what is the clinical features? Mostly it will be asymptomatic, overshadowed by the primary illness normally. This metabolic alkalosis can cause severe hypokalemia and hypocalcemia. This hypokalemia and hypocalcemia can cause a lot of neuromuscular symptoms like muscle cramps, weakness, sometimes it can cause arrhythmia, and seizures are very common because of this severe hypokalemia and hypocalcemia. Sometimes the metabolic alkalosis will be persistent chronic metabolic alkalosis can cause lethargy, confusion, agitation, coma in a very severe metabolic alkalosis. So, how will you interpret the ABG? So, if it is alkalosis means the pH will be high, bicarbonate will be high, the compensatory the PCO2 will be high. We already discussed the expected compensation of PCO2 is bicarbonate plus 10. Okay. If anything is, if example this 30 bicarbonate, my PCO2 should be 50. It is more than 50, it's example 60. What does it mean? Patient having metabolic alkalosis with respiratory acidosis. It is less than 50, it's 40. It means the patient having metabolic alkalosis with respiratory alkalosis also. So, have to be whenever that expected PCO2 response is higher or lower, you have to think about there is one more metabolic acidosis, where my acid base disorder is there. Okay. Just I am summarizing here. So, the treatment of the metabolic alkalosis is to identify the root cause. Okay, it's very important. Then only we can treat that. So, how can we identify? Each disease will have the different patterns. Some causes will have the urine chloride will be low, some will be high, some condition will BP will be low, some condition will be extra, patient will be hypovolemic, some condition will the BP high, hypervolemia. So, based on that we can differentiate that. One is a hyperaldosteronism condition, one is a thiazide diuretics, loop diuretics, it is a GI loss of metabolic alkalosis. There is a exogenous bicarbonate intake. Fourth one is a hypercalcemia related calcium supplementation, milk alkali syndrome, vitamin intake. All these conditions will have the pH more than 7.45. All these conditions will have the bicarbonate level is high. All these conditions will have the secondary compensatory PCO2 used to be high. All these patients will have a low potassium. All these patients will have the low chloride. These are common for all. Okay. The calcium level will be low, all these conditions, except in a milk alkali syndrome or calcium exogenous calcium supplementation. Okay. The BP will be hyperaldosteronism will be high. Thiazide diuretics, loop diuretics, or GI loss of metabolic alkalosis will be low. In excess bicarbonate injection, usually it will be a sodium bicarbonate itself increase the volume of the blood. So, the ECF volume used to be high in this condition. This condition will be variable. Okay. Urine chloride, if you see here in a GI loss condition, okay, the body, the kidney trying to absorb all electrolytes. So, chloride also will be, the kidney will reabsorb, the urine chloride level will be less than 20. It is a GI cause of metabolic alkalosis. In this condition is called chloride sensitive metabolic alkalosis, because if I give hyperchloremic solution to this patient, it will correct the metabolic alkalosis. This is called chloride sensitive metabolic alkalosis. In a hyperaldosteronism condition, here the volume status is normal. Even if I give the normal saline, this patient metabolic alkalosis won't be corrected. It is called chloride resistant metabolic alkalosis. Here there is no volume is normal, even the higher than the normal. So, urine chloride will be more than 20 in a hyperaldosteronism. The thiazide and loop diuretics we already discussed, it is a variable. If I give diuretics, I check the urine chloride will be more than 20. In between the doses, if I check, urine chloride will be less than 20. Okay. In excess bicarbonate, it is a almost hypervolemic condition. Okay. So, urine chloride will be normal, like hyperaldosteronism more than 20. In this calcium hypercalcemic condition, in the early phase, it will be less than 20. After later phase of this condition can cause more than 20. This is not very important. There is two things that are very important. Hyperaldosteronism, urine chloride will be more than 20. It is a chloride resistant metabolic alkalosis. In a GI cause, it will be urine chloride will be less than 20. It will be a chloride sensitive metabolic alkalosis. During the diuretics, patient diuretic induced metabolic alkalosis, the urine chloride will be variable. Okay. Whenever if you see metabolic alkalosis in your ICU, first you have to rule out the chronic respiratory acidosis. It's very important. The chronic respiratory acidosis patient always will have the high bicarbonate. Okay. So, we can rule out. How can I identify? I have example this much of PCO2 60. I have to calculate the compensatory bicarbonate. The compensatory bicarbonate example, it is a 30. Okay. If it is a 30 means there is no additional metabolic alkalosis there. For example, for the 60, ideally it should be 30, but it is around 40. That means the patient having associated with primary respiratory acidosis with metabolic alkalosis also. This is the first step. Second, I have to check 3 parameters to narrow down my differential. One is the extracellular fluid volume, then extracellular fluid, that is my volume status, blood pressure and urine chloride. If sometimes in the vomiting itself, with RT aspiration itself will give idea about the history of GI losses, that patient is having a low BP, low ECF volume, the urine chloride is less than 20, it is a chloride sensitive metabolic alkalosis. Okay, this is a GI related. If it is a diuretic use, also the slow BP will, history of diuretic use is there, low BP, low ECF or not, urine chloride is variable. That means it's a diuretic induced metabolic alkalosis. If I found my BPs are high, ECF volumes also very high, my urine chloride also more than 20, there is a 2 possibilities. One is the exogenous cause, or it may be hyperaldosteronism. Exogenous loading of soda bicarbonate, it can cause these are high BP, high ECF, urine chloride also more than 20. The history will narrow down our diagnosis, or this develop only if the patient having renal dysfunction. If there is no exogenous, BPs are high, ECF volumes are high, urine chloride is more than 20, there is no history of exogenous administration of soda bicarbonate, there is a mineralocorticoid excess, it is a chloride resistant metabolic alkalosis. Don't forget about other causes like milk alkali syndrome or post hypercapnia, or it may be a blood transfusion related, all those things. Okay. take home message, it's a metabolic alkalosis. Usually it's very common, but usually we'll ignore it because there is no, usually it is masked by the primary disorder, okay, the symptoms and signs. And okay, urine chloride, checking of urine chloride is very key to diagnose or narrow down your root cause of metabolic alkalosis. Understanding of kidney physiology and electrolytes very important, because the pathophysiology of the metabolic alkalosis is very important to diagnose to root cause of metabolic alkalosis, and treatment also is depends upon that. Okay, so always correct your valium, chloride and potassium, because it's not correcting a valium or potassium, it will, that metabolic alkalosis will be very resistant irrespective of the cause. Okay, always treat the underlying cause to resolve the metabolic alkalosis. Thank you.